So just to explain in terms of what a dietitian is, a registered dietitian is a qualified nutrition and health expert who provides evidence-based and personalised diet and nutrition plans to treat and help people manage their medical conditions. The dietitians are qualified to undergrad, postgrad level in most cases, are accredited by a body, so in Ireland it's the CARU, so we have a sort of register that we have to be regulated by. We also have extensive clinical training and we do continuous CPD. In terms of dietitians, what do? They deliver medical nutrition therapy, so that's assessing. So a dietitian advises and reviews tests or lab tests results, asks about your health history, your eating habits, your lifestyle. Then they make a nutrition-related diagnosis, work out with the person what is the best personalised plan to address your health concerns. And then in terms of supporting that person with the condition, putting a plan into action, helping the person with the condition put that into place, monitoring and having check-ins and adjusting accordingly along that journey with the relationship between the person with the condition and the dietitian. So I suppose just to kind of highlight the body for dietitian experts in Australia is Dietitians Australia, so you will be able to find dietitians through that website. I suppose my journey to coming here in terms of talking about diet, people with Parkinson's is when I was diagnosed, I immediately thought, okay, great, there must be lots of information about diet for managing Parkinson's. So I went to the World Parkinson's Congress in Kyoto, really excited to learn lots, and actually there was, one presentation. I don't think there was any research, maybe one paper on research. So I kind of thought, okay, it just doesn't make sense. I went back and I researched what was out there, and I saw that actually there's a huge gap in terms of nutritional care for people with Parkinson's. So basically from that time I went to Kyoto, the World Parkinson's Congress in 2019. I've been advocating alongside the hormone stuff for the nutrition access to care. So this is something I put together. I did a paper again with Indu Subramanian and another 2 dietitians on the role of the dietitian in the care of people with Parkinson's. And this just kind of shows you the different areas that a dietitian, these are only some areas, so helping with different diets. So whether it's, in my case, I'm celiac, that I'd need a gluten-free diet, helping with advising around probiotics, prebiotics, the protein redistribution diet, managing dysphagia, helping with food addiction, bone health, blood pressure. We cover the whole area in terms of your nutrition care. It's not just about Parkinson's, and few people just have the Parkinson's. They might have other conditions that need to be managed. So just in terms of access to dietitians, the reality is that 90% of people with Parkinson's do not have access to a dietitian, and that's probably pretty much globally. And in Australia, I was looking at the data, there's 15 dietitians to every 100,000 population of Australians. So that kind of shows you why it's so difficult to get access. And in terms of the Australian population, accessing dietetic services through Medicare is low, ranging from 1.8 to 4%, with most users being women older than 55. So a problem there in terms of men not getting access and possibly not asking for access. And that brings me on to here in terms of what we did a survey of people, a global survey of 154 people, and 82% of people with Parkinson's rated diet as important in their care. In terms of their knowledge of diet, self-rating was about 55%, were poor, very poor average kind of knowledge. So people with Parkinson's consider, diet important, but the knowledge is lacking. And then in terms of referral, 84% of people with Parkinson's were never referred to a dietitian, and 87% of people with Parkinson's never asked to be referred. So people consider it important, but they're not been referred and not been asked to. So this is a thing in the health service, I think globally, if you don't ask, you definitely won't get. And we also did ask people in this survey, what do you want to know? So people wanted to get a personalised approach to diet for people with Parkinson's. They wanted to know about supplements, prebiotics, probiotics, advice beyond the protein medication interactions. What about different diets? They wanted to be culturally specific. They want to know about digestive bowel issues, menopause and PD in diet, anything scientifically proven to improve symptoms, and consistent advice from different dietitians. So this was actually what came across. People were very frustrated with neurologists being dismissive of their need to get nutrition advice. So you'll see here, I asked for a referral to a dietitian, was told by the doctor that I didn't need to speak to a dietitian. I asked neurologists if we could look at diet, the response was move more and eat well. Neurologists don't have a clue, don't see the relevance of diet. No talk of diet by doctors, the info never provided. And sadly, on my own professional side, there was also things that we have to address. Registered dietitians not knowing about PD is off-putting. Conflicting answers between dietitians, giving different versions. Level confusion on the information, a lot of contradiction between dietitians. And that's something that we as a profession need to improve on, and that's something I've been working on. So just in terms of, what diet, everyone asks, what's the diet for Parkinson's? There is no specific diet for Parkinson's, but in terms of the evidence showing which diet is potentially the most beneficial, the Mediterranean diet is by far the one that is showing the most benefit in terms of symptom control and potentially helping to slow progression. So basically they have both garnered a lot of attention because they've been shown to help in terms of reducing dementia risk, preserving cognitive health, and protecting against depression. And research has shown that women who follow the MIND diet delay onset of progression or onset of Parkinson's by up to 17 years. And if men, there was the Greek Mediterranean diet, delayed it up to 8 years. And MIND and MEDI scores are associated with fewer patient-reported symptoms over time. So this is a picture of the food, the Mediterranean diet pyramid. And the core elements of it are on here. I'm not going to go through it in detail. You'll get the slides. But in essence, it is to focus on a plant-based diet, but it doesn't mean that you cut out meats, chicken, etc. You still have meat within this diet. It doesn't say cut out dairy. It's obviously about limiting the amount of dairy. So it's not having like lashings of milk in the day or lashings of cheese in the day. Some cornerstones are making sure that you're getting the olive oil in, you're getting nuts and seeds in, you're getting legumes in, and you're obviously getting a lot of the fruits and vegetables in. And what's very important also, the base of that food pyramid is what I call vitamin C, which is vitamin connection. Because, if you think about the Mediterranean diet, it's about people coming together, eating in a community, and that's part of our health in terms of eating. So, in terms of the Mediterranean diet, there's kind of a Mediterranean diet score, which kind of gives you an idea of how people are, adhering to the Mediterranean diet. So a dietetic colleague who worked with Michael Oken's team in the States, she did a trial, a pilot trial, and basically the average MEDI score of the people who were in that was 4.4 out of 14. We did a kind of survey where we assessed people's MEDI score, and the average is about 6. And so you'll see here in terms of adherence, anything that's less than 5 is weak, fair to moderate is 6 to 9, and good to very good is 10. So pretty much we're not doing too well on the diet score, the MEDI diet score. This, just going to kind of compare now in terms of the Australian diet. This is the Australian Guide to Healthy Eating. And I'm just going to bring you through some sort of facts about the Australian diet intake, which I did over the last while. So 9 in 10 adults, Australian adults, do not eat enough vegetables. 4 out of 5 19 to 50-year-olds do not eat enough fruit. 36% of calories from discretionary food intake comes from discretionary food intake. So that's your cakes, biscuits, treats. Alcohol accounts for 22% of discretionary food intake in adults. Over 80% are not eating enough dairy products or servings. 76% of women, and sorry, I missed out the figure there, I just realized, I think it was in the 60s, not eating the recommended serving of grains. 87% of women and 79% of men did not meet the recommended servings of meat and alternative protein sources. Too much fat in the diet, between 12 and 15. And the salt intake was up to 3.4 times more than the adequate level. So I'm just going to let you absorb that. So in terms of giving you kind of guidelines around the food pyramid or the food plate, you can go on there, the eatforhealth@gov.au, and you can actually put in your age, your gender, and it'll kind of give you a guideline of what your portions of the different food groups are. And a lot of people dismiss the food pyramids around the world, but actually they're based on a lot of evidence in terms of trying to make sure that everyone gets enough macronutrients, so your fat, protein, carbs, and your micronutrients in terms of your vitamins and minerals. And a lot of people with Parkinson's are actually deficient in macro and micronutrients. But this is just talking in terms of general Australian population. So just in terms of what a serving of fruit is, if you want to just all stand up, I'm going to get to do a little exercise for you and wake you up after lunch. So all stand up there. If you can, obviously, be careful if there's any problems with balance. So a standard serving of fruit is like a medium apple, orange, banana. It's 2 small fruits, like say a plum and a kiwi. It's a cup of canned fruit. In terms of fruit juice, it's 125 mils. That's 1 serving. You can't have 500 mils and call that 3.5 servings. In terms of vegetables, it is a half a cup of cooked or green or orange vegetables. It's a half cup of cooked or canned beans or peas and lentils. A cup of green leafy salad vegetables. Okay, so what I'm going to ask you is, if you think of yesterday, I want you, those of you who had 1 serving of fruit and vegetables, to stay standing. If you had no fruit or vegetables yesterday, I want you to sit down. So you all managed to have 1, that's great. So those of you who had 2 servings of fruit and vegetables yesterday, I want you to stay standing. So if you didn't have 2, you can sit down. Those of you who had 3 servings of fruit and vegetables yesterday, I want you to stay standing. If you didn't have that, you can sit down. Those of you who had 4 servings of fruit and vegetables yesterday, stay standing. Those of you who had 5, 6, and we didn't get to 7. So, and actually in terms of the requirement is between 5 to 7 servings a day, and the average there was probably 3 to 4. And that's kind of fairly common when I do this across many populations. But if there's one thing that you can do to improve your health for Parkinson's and other conditions, is to up your servings of fruit and vegetables. And I suppose that's what I'm about. It's no magic pills at the moment. It's actually the low-hanging fruit, no pun intended, but actually, looking at those basic building blocks to improve your health. So in terms of the Australian dietary intake of sugar, this is the amount. So 18 teaspoons in the age group between 19 and 30, and up to 11 teaspoons a day in the 70 plus. The requirement in terms of health is no more than 9 teaspoons a day for a man, or 6 teaspoons a day for a woman. So you can see there that in the younger group, 19 to 30-year-olds, they're taking twice the amount. So this is what we're doing, it's the world over. And in terms of discretionary foods, as I mentioned, 36% of total energy calorie intake comes from these discretionary foods. That's 5 to 7 servings a day. Really, discretionary foods should be a couple of times a week. They're not supposed to be eaten on a daily basis. And the main contributors to that are your cereal-based products, such as sweet and savory biscuits, cakes, muffins, pastries, confectionery, chocolate, snack foods, all of these things. And in terms of the Australian dietary intake, this is basically shows you in terms of what age groups are meeting the food group guidelines. So no one is meeting it, bar the 71-year-old females are meeting their grains. Otherwise, we are not meeting any of our food group requirements in Australia. So the larger the proportion, so a lot of the diet is ultra-processed foods. The larger the proportion of the diet that contains these UPFs, the lower the nutrient density of your diet. And the overall micronutrient content was lower in diets, higher in ultra-processed foods. And the dietary contents of vitamins A, E, C, B9, B12, zinc, calcium, iron, magnesium, potassium, phosphorus were reduced significantly in the consumption of UPF. This is a specific study in Australian people. So this is part of the problem. And it's a problem sort of world over. In terms, this is a very busy slide, but it was just, I was looking and actually was searching to find, and it's one thing and it's why I'm raising about dietitians, and is to get dietitians and nutrition researchers involved in assessing what the landscape is like for people with Parkinson's in Australia. So basically it was showing this is not people with Parkinson's, this is just the Australian population, tend to be low in vitamin B12. So low serum vitamin B12 was found in 3% of participants in a study in New South Wales. And also there was an association with very low vitamin B12 with high homocysteine. That is a big issue for people with Parkinson's. So it's just something, and it was interesting, I kind of did a quick sort of asked a few people, have you had your vitamin B12? And quite a few people were vitamin B12 deficient. So actually I'm just going to ask the audience here, how many of you with Parkinson's have been told that you're deficient in B12? So it's a handful. So a smattering there. So many of you have got your vitamin B12 checked? Okay. So many of you not got your vitamin B12 checked? Yeah, so more hands. Okay, so you need to get your vitamin B12 checked, your folate checked, and your, if you can, riboflavin checked as well. The other thing then is vitamin D. So the left-hand picture here of Australia is basically the vitamin D deficiency levels in the summer. And then the right is the vitamin D deficiency levels in the winter. So considering that you are like an amazing country of sunshine all the time, it's pretty staggering that there's actually quite a lot of vitamin D deficiency. And I believe someone was saying that the rickets is starting to appear again. And this is because basically your vitamin D works off your skin, your sunlight on your skin. So obviously in Australia, paranoid about cancer like we all are, slap on the sun cream, and that basically blocks the action of vitamin D on your skin. So you should be out taking about 10 to 15 minutes in the midday sun to try and counteract that to make sure you get enough vitamin D. But to be honest, people with Parkinson's generally should be taking a vitamin D calcium supplement year-round. However, what I'd say is I would get it checked first, and also make sure that you don't have hyperdoses of vitamin in your blood, vitamin D. So this just shows you here, again, Australian dietary risk factors in relation to the total years of healthy life lost due to illness or disability. So basically it shows a diet that's low in legumes, a diet that is low in whole grains and fibre cereals actually leads to a much higher, greater risk of losing more life years. As you can see there in terms of all the different dietary factors. In terms of Australian dietary risks and chronic disease, all dietary risks combined contributed to 50% of total coronary heart disease, 26% of bowel cancer, 26% of type 2 diabetes, and 26% of stroke burden. What's really interesting is they do not have any stats on neurological conditions in terms of the impact. So I think that's something that would be worthwhile maybe approaching them about. But the reality is with Parkinson's, there's a high risk of cardiovascular, diabetes, so it makes sense that it is also going to be account for a lot of the burden of Parkinson's disease as well. In terms of, again, just going into a bit more detail, men experience greater amount of disease burden due to dietary risks more than females in all ages up to 84. The total disease burden attributed to dietary risk factors is twice as high in the most disadvantaged versus the least disadvantaged. And on average, living in major cities or in higher socioeconomic areas have better food and nutrient intakes, higher levels of physical activity, and lower levels of overweight and obesity. So I just wanted to kind of also look at the indigenous population as well. So only 4% eat enough vegetables. I mean, it's a bit like the 9 out of 10. 39% eat enough fruit. There's a higher rate of illness and disease they experience versus non-Indigenous Australians, and it's really directly related to food insecurity. And the combined effect of dietary factors in this group is the second highest contributor to the burden of disease behind smoking. And 1 in 5 self-reported they had run out of food in the last 12 months and could not afford to buy any more. And basically food insecurity doesn't just affect the Indigenous population, affects everybody in Australia. Due to cost of living crisis, low incomes, geographic isolation, social isolation. And people with Parkinson's, it's not good for us when we are isolated geographically or socially. And also in terms of food insecurity, these are the type of people who suffer from it. Low income earners, people who are, say, isolated, the Indigenous, culturally and linguistically diverse groups, single parent households, older people experiencing homelessness. I don't know if it's the same here, but in Ireland, we do have a crisis of homelessness. So 48% of households with less than 30,000 in income become food insecure, up 5% since 2022. This compares people with income of under 30,000 to those over 95,000. So it's a bigger problem, obviously, in the less. And what happens when you're insecure is you basically, from a diet point of view, it shows that people stop purchasing dairy products, they reduce purchasing fresh produce, they reduce purchasing protein. And these are really important sources of the key nutrients in our diet and for our health. So just back to in terms of Mediterranean diet, does it work? So these are a few sort of snapshots that I got from sort of online. And basically it's showing here that new research has found consuming more nuts, fruits and legumes and fewer sugary drinks may help people over 60 feel less anxious and stressed. Also, there's a huge researcher here called Felice Jacka, who's doing a lot of research in terms of the impact of diet on major depression and showing extremely positive results. This actually was a literature review that was done by an Australian nutrition researcher. I can't remember where she was out of, but it showed that adherence to a healthy diet with higher intakes of fruit, vegetables, fish, and healthy fats, such as the Mediterranean or the MIND diet, are associated with better outcomes for Parkinson's. Adherence to these patterns were found to lead to improved outcomes in all of but 2 studies that were measured in the review. I think there was 34 papers in the review. Interestingly, all the intervention studies led to improvements in symptoms regardless of the dietary pattern being implemented. And it implies that the provision of nutritional guidance in the form of suggested daily or weekly menu plan is of value in the care of people with Parkinson's. And then in terms of randomized controlled trials, they are small, but they're definitely showing signals. So this one was done in 35 patients, showed adherence to the Mediterranean diet over 10 weeks only. Their executive function improved, language improved, attention improved, concentration improved, active memory improved. Their total cognitive score improved. Then there was another study of the same researcher in 70 patients, showed that it significantly increased the total antioxidant capacity, which is what we think is the power underneath, one of the parts of the power underneath the Mediterranean diet, and the UPGRS score improved as well. And then again, that colleague that I mentioned that did a small pilot, she did a 5-week Mediterranean diet intervention in 8 people with Parkinson's, improved constipation, altered the microbiome, and there was some associated weight loss. Because it's such a healthy diet, it tends to be lower in calories. So if you're someone who is underweight, you really need to make sure that it's a high energy Mediterranean diet. Does medical nutrition therapy work? So there's not very many studies in it because there hasn't been very much focus on it, but this just shows you one very powerful one, a 6-week nutrition intervention with a dietitian and nutrition nurse. The patients were given, or people with Parkinson's were given oral nutritional supplements for those who were malnourished. They were given extra fiber, so you should be taking in about 30 to 35 grams of fiber a day. They were supplemented with B12, D, or folic acid if they were deficient, and they were put on a protein redistribution diet within a maximum of 1 gram per kg. They were generally 60 to 68 years old. Almost 68% of them had an abnormal nutrition status when they started. 25% were malnourished, 42% were at risk of being malnourished, and their poor nutritional status affected depression and anxiety. Those with malnutrition or risk of malnutrition had more severe Parkinson's symptoms in all subgroups of the scale, the UPGRS scale, including mental, motor, activities of daily living, and complications. So, with this 6-week trial, they had a significant increase in their malnutrition score. They had a significant improvement in their disease severity, their quality of life, and their nutritional status. They had a significant improvement in their self-perception of nutrition and health status, with a decrease in depression and anxiety scores. So as this author said, nutritional status assessment should be a standard approach in Parkinson's. Although future research is still needed on the role of nutrition in progression, disregarding the nutritional features in PD theoretically worsens the disease process and quality of life. And as a dietitian who's seen people been ramped up in medications because their symptoms are getting worse, and actually sometimes it's because they've vitamin B12 deficiency, they're constipated, they've gastroparesis, we need to deal with these things first before, going up in the scale of drugs. So this was actually the call to action from the paper that we wrote and we presented at the World Parkinson's Congress. We want to improve access to dietitians, provide specialised nutrition training to dietitians to bring them up to speed, provide nutrition training to neurologists, nurses and health professionals, include the dietitian as a core member of the MDT because they're not going to get you referred to them. Included in the Movement Disorder Society team training, update guidelines in terms of dietetic management, increased research into dietetic interventions are really important, and provision of personalised nutrition advice for people with Parkinson's. And ultimately to signpost initially is the first port of call to provide access to evidence-based nutrition education programs. So this kind of brings me on to something I've been working on along the way, alongside the hormone stuff, is actually to try and provide access to evidence-based nutrition care for people with Parkinson's. Because the reality is, we're not going to have enough dietitians trained anytime soon, but we're working on it to improve that awareness. So basically I've been working on developing an online nutrition program. The first one is called MediPD, which is actually focusing on, because everyone keeps asking, what diet should I follow? So I'm just going to show you here. So basically, It's about helping people to understand how and why you should incorporate a Mediterranean diet into your life as someone with Parkinson's. And actually, we got some funding from Parkinsons UK to do some innovation funding to test it within 30 people with Parkinson's in the UK. So I'm just going to, can you play that? Please, do I have to do it or do you do it? Hang on, go back.
Like carbohydrates and proteins, it is essential that we eat fats in our diet. They play an important role in our brain health and our nervous system, particularly omega-3 and 6, the fat we get from oily fish, seeds and nuts. They're needed as an important source of energy and to absorb vitamins A, D, E and K.
So just the reason I'm playing that is she is an avatar. I don't know if you noticed that, but when we did interviews with 10 of the people out of the 30, 3 of them actually thought it was a real person. So what I'm trying to do is use technology to scale access to dietetic information and education. So we basically we tested it for 3 weeks just to see what people thought of the content, did it meet their needs, and it was basically developed directly out of a focus group I did with the University of Ulster and Coleraine with people with Parkinson's in terms of what they wanted, and this is what they wanted and this is what we built. And then we asked them to sort of feed back to us. And the results have been very promising, and these are a few photos that people actually spontaneously sent me in terms of what they were doing to change their diet. And this was the user feedback. 90% were satisfied or very satisfied or satisfied with the program. 79% found it very important that the information was provided by registered dietitians. 78% felt more confident talking to the health professionals about their nutrition needs. The likelihood of making dietary changes was 9.4 out of 10. We also did a kind of nutrition quiz, and that score improved from 65 to 84%. And we did a Medi-PD score, and that went from 44 to 60%, which we weren't expecting because it was only to test the kind of content that actually there was outcome improvement. And there was actually 2 people out of the 10 that we interviewed that actually improved their bowel movements. And what was very interesting is we had across their whole range of from young onset, early onset to late onset, we had people who had Parkinson's for between 11 and 20 years who reported this the first time they had a proper bowel movement in terms of regular bowel movements, which is kind of unbelievable. They've had Parkinson's that long and they haven't actually had advice to help with that. So that is it. I'll take any questions. Thanks.